This is the sixth in a series of discussions of issues important for patients with chronic illness from mold and post-Lyme. Here's the good news about NeuroQuant from Dr. Richie Shoemaker.
Over the years, one of the difficulties we've faced looking at patients with chronic inflammatory response syndromes is what is the mechanism of the incredibly common presentation of neurologic and psychiatric symptoms these patients always have. Are these people all just crazy? Are they making up their symptoms so they can get a pittance from Social Security disability? Actually, no. These symptoms are present. They're present because there's an inflammatory response in the brain. If we look at MRI studies, we will see that there are so-called UBOs, or bright objects, or gliosis, as we might want to call it, that are seen far more commonly in patients compared to controls, but UBOs don't tell us where and how the illness is causing neurologic problems. If we look at magnetic resonance spectroscopy, we can see reduction of the ratio of glutamate to glutamine, showing there's far too much inhibition of neurotransmission compared to activation. And we can also see elevated lactate, showing there's not enough oxygen delivery. But even these sophisticated findings don't give us specific indication as to what exactly is going on with neurologic problems, depression symptoms, anxiety, intrusive thoughts, trouble controlling urges to speak, so-called executive inhibition is gone. We see so many problems with unusual seizure-like movements, tremors at rest, even tics, facial spasms that are not thought to be specific are far more common in patients compared to controls. Fortunately, now that we have access to NeuroQuant is a volumetric program that was developed and FDA cleared in 2006, primarily used in people with traumatic brain injury. But NeuroQuant lets us use 10 minutes of MRI time at a very low cost to develop volume changes typical of those seen in patients with illness acquired following exposure to the interior environment of water-damaged buildings, and separately for those with post-Lyme syndrome. Specifically, the problem comes from defects created in the blood-brain barrier by inflammatory responses. Here's where my good friends, transforming growth factor beta 1, matrix metalloproteinase 9, and vascular endothelial growth factor really add together to destroy the integrity of the blood-brain barrier, letting fluids and foreign chemicals enter the brain that normally would not. We can see the fluid increase inside brain areas, and we look at 11. This increase in size is called microscopic interstitial edema. Quite a mouthful for sure. It doesn't show up on MRI, so it's not macroscopic, but specific enlargement of areas of the brain gives us a typical fingerprint that we can see from mold patients, separate from normal patients, separate from ciguatera, separate from post-traumatic stress disorder, and separate from Lyme. Fascinatingly, what we also see is loss of size of the caudate nucleus. The caudate nucleus sits in the bottom part of the brain next to the thalamus and next to the putamen, and it integrates so many fibers coming from the front part of the brain to the back. With caudate atrophy alone, you almost always have a mold patient. Interestingly, post-Lyme patients don't have caudate atrophy, but they have putamen atrophy. As we go forward with publication of this exciting data, we will be adding more findings with more diseases. But as we stand here now, the ability to spend less than $100 in less than 10 minutes with an MRI to give us specific indications for Lyme and mold is incredibly exciting.